Welcome to the Explainer. Today, we're jumping into one of the most critical skills in all of medicine, the primary survey. We are going to break down the life-saving framework that lets you bring order to absolute chaos. So let's just dive right in with a scenario that anyone on the front lines is going to face. Your patient is crashing. A dozen things are going wrong all at once. Where do you even start? And that right there, that's the absolute core of emergency medicine. See, in the middle of all that chaos, you don't have time to hunt for some perfect, elegant diagnosis. Nope. You rely on a structured system to find and fix the things that will kill your patient right now. And today, we are walking through that exact system. It's the gold standard for a reason, the ABCDE primary survey. We're going to break down every single step and then see how it all clicks together in some really high-stakes situations. Okay, first things first, we always start with A for airway. The question is simple. Is the path for air to get to the lungs open, and can the patient keep it that way? Because if you don't have an airway, nothing, and I mean nothing else you do is going to matter. Think of this as your survival checklist. You're looking for any kind of obstruction. You're listening for stridor. That's that awful high-pitched sound of a tight airway. If there's any chance of trauma, you are protecting that cervical spine. And if a patient's level of consciousness is low, you have to ask yourself the big question, can they protect their own airway? If the answer is no, well, then you've got to do it for them. All right, so you've secured the airway. Now let's move to B for breathing. This is crucial because, just because the airway is open doesn't mean the patient is actually breathing effectively. The highway might be clear, but is there any traffic moving on it? So here, you're using your eyes and your ears. What's the respiratory rate? What's the O2 sat? Then you listen. Are you hearing the wheezing of an asthma attack? Or maybe the crackles of fluid in the lungs from heart failure? Or, and this is a scary one, are you hearing nothing? Decreased or absent breath sounds could mean a collapsed lung. Every sound or lack of sound is a massive clue. Next up is C for circulation. This is all about perfusion. Is oxygenated blood actually getting to the brain, the kidneys, all the vital organs? This is where we have to find and start treating shock fast. Now this is such a high-yield clinical pearl. It gives you two simple but incredibly powerful signs that your patient is going downhill. Think of blood pressure and urine output as direct windows into how well the organs are being perfused. If they're both dropping, you are losing the battle. And here's another fantastic little tool for your brain. If the patient's skin feels cold and clammy, their body is clamping down, trying to shunt blood to the core. That screams volume loss. But if they're warm and flushed, especially in the beginning, their blood vessels are wide open. They're vasodilated. That's a classic sign of something like sepsis. So this table really breaks down the three main types of shock you're going to encounter. For hypovolemic shock, like from a major bleed, the tank is empty. You have to replace the volume. For cardiogenic shock, the pump, the heart, is failing. So your priority is to help the heart do its job. And for septic shock, the pipes are leaky and dilated. So you hit them hard with fluids and then often add pressors to squeeze those vessels tight again. Okay, on to D for disability. Now, this isn't about long-term stuff. This is a rapid, right here, right now, neurological check. What is happening in the central nervous system? The whole point here is to figure out fast if there's a major problem with the brain. You're checking their level of consciousness, you're looking at their pupils, and you're getting that Glasgow Coma Skill score we talked about earlier. And right here, this is where you see how brilliant this system is, how it loops back on itself. A GCS of 8 or less, that's a huge red flag. It tells you the patient probably can't protect their own airway. So a finding down here in D sends you right back to reconsider your plan for A. It's all connected. It's a dynamic process. And finally, we get to E for exposure. Okay, we've dealt with all the immediate life-ending threats. Now it's time to look for the clues we might have missed. This step is a real balancing act. On one hand, you have to expose the patient completely. You've got to see everything from head to toe, because you can't treat what you don't see. But the second you do that, you create a new problem, hypothermia. So you look, you assess, and then you immediately get them covered with warm blankets. Expose, but protect. So we've got the framework. Now, let's really put it to the test. Let's see how this beautifully simple system holds up in one of the most chaotic situations imaginable, a bioterrorism event. And this just shows you how powerful the ABCD approach is. With a nerve agent like sarin, your A and B assessment is going to scream cholinergic crisis, pointing you straight to the antidote. With anthrax, it's B for breathing that's the killer, that rapid respiratory distress. And for smallpox, it's E for exposure that uncovers that telltale rash, making isolation the #1 priority. The system keeps you focused.
So let's just lock that mental checklist in one last time. A for airway, is it open? B for breathing, are they ventilating? C for circulation, are they perfusing? D for disability, what's their neurostatus? And E for exposure, what else is going on that I can't see?
And really, that's the biggest takeaway here. The most powerful tool you will ever have in an emergency isn't some fancy piece of equipment. It's this system, hardwired in your brain. Mastering this mental model is what truly saves lives when the seconds are ticking away. You stay systematic and you stay in control.